Welcome back to Advanced Human Gross Anatomy. Today's dissection is number 16. Today we'll be talking about the forearm, the hand, and some of the joints of the upper extremities. So today we'll be finishing up our section that we've been working on the back and the extremities. And that's exciting. We finished up after today a whole other section of our course. So let's just get right into some of the skeleton of the distal humerus. We talked a bit about the proximal humerus last time, and the shoulder blade, the scapula, and the proximal humerus. Now, if we look at the distal ends here, first things we'll see are these epicondyles. So we've got condyles and epicondyles. Condyles are, think of the points of articulation. This is going to be where joints articulate. So that's going to be down here, but these epicondyles are just above that. You've got a lateral and a medial epicondyle. We'll learn later on when we see the musculature, there's a lot of muscle attachment sites to both the lateral and the medial epicondyle. The condyles, though, there's two of them that we'll speak about in the distal humerus. The one most laterally here is called the capitulum. Capit means head, but you're thinking, well, the humerus already has a head, it's proximal. But this is actually going to accommodate the head of the radius to make up the elbow joint here. So the capitulum is on the lateral side, and on the medial side you've got the trochlea, which means pulley. And that's an attachment site for the proximal ulna, which will sit right in here. You see some of these bumps on the elbow. Let's look at the back side here. The distal end of the humerus, the back side, the posterior aspect has a big bump here, the olecranon fossa. And this is going to be in full extension. Here you can see the elbow, or the ulna put into to make up the elbow joint here, but the ulna has an olecranon process on the back. And when the elbow is fully extended, that olecranon process has to go someplace. It has to fit into a portion at the distal end of the posterior humerus. So that's going to be the olecranon fossa that will receive the olecranon process of the ulna. Back to the anterior side, there's a coronoid fossa, which is right here. The front portion, the anterior portion of the ulna, that kind of sits in that trochlea, is called the coronoid process. Now, coronoid also means beak. Remember coracoid? Don't get that confused. Here's the coracoid process of the scapula and the coronoid process of the ulna. Now, to make it even worse, later on we're going to talk about the coronoid process of the mandible too, but they all look like little beaks, so they have similar names. But the coronoid process of the ulna, when the elbow is in full flexion, that needs to be put someplace. So this coronoid fossa here will accommodate that coronoid process when the elbow is fully flexed. On the radial side, the head of the radius sits on the capitulum here, but in full flexion. Again, that head of the radius needs to go someplace, so there's a radial fossa at the distal end of the humerus as well. These are named for what they receive, not what bone they're on. So the radial fossa is on the distal humerus. Hopefully that makes sense. Okay, when we talk about the bones of the forearm, we'll see the radius, which is going to be on the thumb side, and the ulna, which will be kind of on the little finger side down here. Okay, these two bones make up the forearm. They're connected in the middle by an interosseous membrane, which helps to keep them together. They run parallel to each other with full flexion and full extension of the elbow joint, but also mostly think about that they're parallel when the forearm is supinated. Here you can see how the radius has flipped over the ulna, so it will spin, it will rotate at the capitulum here, and muscles will pull this over and rotate it over. Now you can see it kind of makes these two bones make a bit of an X when the hand is in pronation. But supinated, they'll be parallel, and then they'll make this X here when they're in pronation. Okay, the head of the radius is the proximal portion here. This is what's actually going to connect to the capitulum. So capit, meaning head, will receive the head of the radius. Just distal to the head of the radius is the neck, just this little smaller portion here, distal to the head. Distal to the neck is this big bump here, this radial tuberosity. This is going to be a bump on the anterior portion, just distal to the neck, attachment site for the bicep brachii muscle. Helps to flex at the elbow. That's the proximal portion of the radius. The distal portion of the radius, you've got a little bump right here at the end of your radius. The nice part about anatomy is you've got this. So actually, as you're learning this, I would encourage you to use your hands, feel the end of your radius on the thumb side here. You'll feel this kind of this edge, kind of a sharper beak-like portion there. Ooh, good thing we don't call it the coracoid or coronoid, but the styloid process. It's medial, just medial to this, right about here, to the styloid process. You'll find the radial artery. So this is a place that you'll often use to check somebody's pulse. Is finding that styloid process on the radial side, sliding your fingers right into here onto that radial artery to get your pulse. So that's a place you can try that. The ulna now, the proximal portion. This big, to me, it kind of looks like a big ice cream scooper here. One of those Pampered Chef ice cream scoopers. The big portion on the backside here is called the olecranon process. If you put your elbows on the table, this is what you're putting your on the table. The olecranon process of the ulna, right here. The proximal. Just that the proximal portion, big bump on the backside. The coronoid process we've already touched on here is this portion on the front, kind of like the front of that ice cream scooper. Coronoid, again, also means beak. So just, sorry about all the beaks here, but try to get that not confused again with the coracoid process of the scapula. And then the trochlear notch. So the trochlear notch is going to receive, that's where the trochlea sits of the distal humerus. So again, the trochlear notch is on the ulna. The radial notch is on the humerus. So hopefully you're getting the idea that it's named for what it connects to, or what receives it, or what it accommodates, not necessarily what bone it's on. It's the trochlear notch here between the olecranon process and the coronoid process of the ulna. The head of the ulna is actually distal. Head of the radius is proximal. Head of the ulna is a distal end here. This is going to articulate with the carpal bones of the wrist. You also have a styloid process, a little bump here on the outside of the ulna, so you can feel that as well. So now let's get into some musculature. What I'd like you to do, we've already removed the skin on the arm because we did that last time to look at the musculature of the arm. Now you're going to make an incision right down the forearm, kind of right down the middle of the ventral forearm, and then just work your way around, remove the skin on the anterior and eventually the posterior forearm. But you can kind of just take that off. That shouldn't be too hard to separate and to take off. And we can put that again in our bins for the safe storage of tissues. And the first muscle you'll see, or you'll want to identify here, is called the brachioradialis. Now, the brachioradialis originates off of the lateral epicondyle. It's the only muscle, interestingly, on the anterior aspect of the forearm that doesn't come off of the medial side, but the brachioradialis coming off of that just superior to the lateral epicondyle. And it's going to come down, way down here towards the radial side here. Let's see, what else do I want to say about that? If you clean this area up, actually, let me show you this picture here. If you you can see how Netter has drawn a probe kind of right here, pulling back the brachioradialis. What I'd like you to do is something similar. Find the brachioradialis, kind of peel it back a little bit. And what you'll find here is the underside, right, sitting on top of the supinator muscle. Excuse me. You'll find the superior branch, the superficial branch of the radial nerve. So the radial nerve sits here. It's going to come down and mostly go into the posterior cavity of the forearm, but the superficial branch of the radial nerve is going to sit right inside here. Now this provides motor innervation to the brachioradialis muscle. No sensory innervation here, but when it emerges through the radial artery proper, the radial nerve proper on the dorsal side of the hand, it will carry all of that sensory information onto the back of the hand. So radial nerve will go into the back of the hand, but there is this superficial branch that you can find right there. Right along with that, you'll see the deep branch. The deep branch of the radial nerve. Let's see, what am I trying to say? Oh, the deep branch, yeah, that's going to continue down onto the back side of the hand. Sorry, that's what's going to provide the motor innervation to the wrist extensors and the sensory information to the back side of that area back there. Okay, so hopefully you can kind of peel that up and see there. Here you'll also see the radial artery as it travels down along with the superficial branch of the radial nerve. Okay, now go back to this picture. Here, a couple more muscles I want you to find on the flexor side. Brachioradialis, pretty easy to find like you've seen. Now if we go towards the medial side, you'll find the pronator teres muscle. Remember, teres means rope. This is going to be a pronator teres. The name gives it away as its function, but remember that you can always tell the function of a muscle if you just bring the insertion toward the origin. So let's figure this out. The origin comes from the medial epicondyle, and a little bit of that the coronoid process of the ulna, and it inserts on the middle lateral portion of the radius. So if we bring that portion of the radius closer to the medial epicondyle, you're going to pronate. That's what's going to turn that head of the humerus in the capitulum and make an X with that radius flipping over the ulna. It's going to pronate the hand. Okay. If we keep going laterally here, flexor carpi radialis, which is right here, the next one down, again off of that medial epicondyle of the humerus, travels next to the carpi travels next to, let's see, kind of in between the pronator teres and the next one here called the palmaris longus. But the flexor carpi radialis inserts then down onto you can't really see it here, but onto the base of the second metacarpal bone right down here. So it's going to help mainly flex that first digit, the second digit, the pointer finger, the index finger, the metacarpal number 2. Next to that, going more medially, you'll find the palmaris longus, again off of the medial epicondyle, traveling next to the flexor carpi radialis muscle here. This is going to come down and insert into the aponeurosis and the flexor retinaculum here, right on the anterior side of the wrist. If you pinch if you pinch the distal phalanx of your 5th digit, your little finger, and into the distal phalanx of your thumb, and then slightly flex the wrist, you'll be able to kind of see it pop out of the forearm right here. You should be able to kind of see that tendon really pop out right there. Because remember, this does not go into the metacarpals. It doesn't go into the hand. It just sits right on that flexor retinaculum. So if you pinch the tips of your thumb and your little finger together, slightly bend your wrist, you'll see that pop out. Now, in about 15% or so of the population, it's absent. Some people don't have this tendon. But if you do, it can sometimes be helpful for a graft site, an allograft used for ulnar collateral ligament repair. I've seen that done for somebody getting a Tommy John surgery at the elbow. But it doesn't really have anything to do with your grip strength because it doesn't come into the hand or the fingers. So, but the palmaris longus, interesting muscle there. The flexor carpi ulnaris, this outside muscle coming here, again coming from that medial epicondyle of the humerus, and then wrapping itself down, comes all the way down to the wrist and attaches to the pisiform bone, the hamate bone. Those are carpal bones we'll learn in just a few minutes, as well as the proximal portion of the 5th metacarpal bone. So down here, it's going to help flex and ulnarly deviate the wrist. Okay, now if we take that layer off and go one layer deeper, here's that picture I showed you with that superficial branch of the radial nerve and the radial artery coming just underneath the brachioradialis. Here you can see the pronator teres has been cut. Here you can see flexor carpi radialis and palmaris longus have been cut. So that's where they would be. Now we're deep to that now. So if we go deep, now you can see this muscle here is called the flexor digitorum superficialis. So this is a big muscle. It's going to help flex the digits 2 through 5, but it comes again from the medial epicondyle of the humerus and inserts onto the proximal portion of the middle phalanges of digits 2 through 5. So those last 4 digits, the medial 4 digits. So it's going to help flex, but going to the medial, to the middle phalanx there. Okay, so in this view, what you can see when you get down to this point in your dissection, you should be able to identify a few things here. You'll be able to identify the ulnar nerve and the ulnar artery. These are going to go between, you kind of find them right between the flexor digitorum superficialis tendon and the flexor carpi ulnaris tendon. That's right where they are. They're going to go anterior to that flexor retinaculum here. And then here you should be able to find the median nerve right in the middle here, going right through the carpal tunnel there. You should be able to find that. And then the radial artery, which is right in through here, just medial to the brachioradialis tendon. Superficial branch is going to go, you can see a superficial and a deep branch. They're going to kind of surround that flexor retinaculum. The superficial is going to go anterior to it. Deep is going to go posterior to it, looping kind of behind that first metacarpal, that deep branch. The superficial branch here of the radial nerve, you can see there it's going to come down and it's going to go under the brachioradialis muscle on top of the dorsum of the hand for sensation innervation of that, like we talked about. Okay, now if we take that down, let's go one more layer deep, and the muscle we'll talk about now is the flexor digitorum profundus. If there was a flexor digitorum superficialis, there must be a flexor digitorum profundus. And so here's the profundus. Let's see, deep to the superficialis. It originates off the proximal anterior ulna, actually. So that doesn't come up as high as the medial epicondyle. It doesn't cross the elbow, in other words. And it's going to insert down, can't see it here, but it's going to keep going onto the distal phalanges of digits 2 through 5. So the superficialis is going to go to the middle phalanx, and the profundus is going to go to the distal phalanx of the 2nd, 3rd, 4th, and 5th digits. Okay, the tendon sheath we'll see later on here of the flexor digitorum superficialis actually splits as it inserts onto that the middle phalanx, and it allows the flexor digitorum profundus tendons to travel through that split as they continue onto the distal phalanx of each digit. It's actually pretty amazing. We'll show a picture of that in just a few minutes at near the end of this. Another muscle here at the distal aspect of the radius and ulna is the pronator quadratus. Again, its name gives it away. It looks like a four-sided muscle. Actually, to me, it kind of looks like a sweatband that they used to wear in basketball in the 70s. But it's a pronator, so it's going to help pronate the hand again. Then we had the pronator teres, and then now here's a pronator quadratus. But this is the distal aspect. This is going to originate from the distal anterior ulna and insert on the distal anterior radius, pulling the radius as it contracts. It'll help pronate that distal part of the radius over the ulna. Okay, moving on to the hand. Let's talk about the hand a little bit here. Now, there are two big muscle masses in the palm side of the hand. Much of the musculature is going to be found on the palm side, the anterior side of the hand. And that's because most of your time with using the hand, it's going to be with flexion. You're going to be grabbing things or pinching things or lifting, carrying things. And two big muscle masses here. There's a thenar eminence and a hypothenar eminence. Thenar refers to thumb. Hypothenar refers towards the little finger. We're not going to learn all of these muscles specifically, but rather just learn them as a group, the thenar muscles and the hypothenar muscles. There are some interosseous muscles here in between the metacarpals. And just like in the foot, remember we used the mnemonic DAB pad, D-A-B-P-A-D, dorsal on the dorsum side. On the back side, These are going to be to pull apart. They're going to pull the hand apart. Let's see, the dorsal view here. Here we go. The dorsal view, when these interossei are going to actually dorsal AB duct. They're going to pull apart. They're going to bring the fingers away from midline. The palmar side, PAD, the palmar side are going to adduct, pull together. They're going to come toward. They're going to bring the other fingers toward the middle finger. Okay, so dab, pad. And that's really all I really want to study for the musculature of the hand for this course. You'll study more of these later on if you go on to grad school or medical school or some other type of program where you might need to learn more particulars about musculature with the hand. It does get very intense, but I think that's going to be all we talk about for this course. Now, let's talk about the wrist, the carpus of the wrist. The carpus is the wrist, which is made up of 8 carpal bones. So there are there's a proximal row of 4 bones, and there's a distal row of 4 bones. And the proximal row will articulate with the distal end of the radius and the ulna. The distal row will articulate with the proximal metacarpals, right down here. And these allow for a tremendous amount of mobility. All these synovial joints in here will each allow just a slight amount of movement by themselves, but together they allow a lot of mobility here as a whole. I just think it's amazing that there are 15 bones right here, just between the distal end of the radius and the ulna and the 5 metacarpals, and these 8 carpal bones that make up the carpus. Carpus means wrist. Here, let's just go through them so we can identify. Now, there is a mnemonic. There's lots of mnemonics for this. You could hear this from anybody who's teaching this, but everybody's kind of got their own mnemonic. I'm going to use one that I think is most helpful for me. I hope it's helpful for you. We're going to go straight line to pinky. Here comes the thumb. Okay, so straight from the proximal row. This always works because you can always tell where you're going. It's always going to go proximal row, distal row, and it's always going to go from the thumb side to the pinky side and the pinky side to the thumb side. So straight line to pinky, here comes the thumb. The straight is the scaphoid. Line is the lunate. 2 would be the triquetrum, right here. And pinky is a pisiform. So you can't see it from this angle here, but if you see it on the anterior view, on the palm side view, the pisiform kind of looks like a P. That's how I remember it. Pisiform kind of sits right in front of the triquetrum here. So straight line to pinky, scaphoid, lunate, triquetrum, pisiform. Okay. Now let's go to the distal row. Here comes the thumb. Now remember that old Beatles song, Here Comes the Sun? You can sing it if you want. I don't think I'm going to do that to you on this recording, but here comes the thumb. Anyway, sorry about that. Here comes the thumb. You just have to, I think. The hamate here comes, capitate, the trapezoid, thumb, trapezium. Here comes the thumb. Scaphoid, lunate, triquetrum, pisiform, hamate, capitate, trapezoid, trapezium. Scaphoid, lunate, triquetrum, pisiform is kind of on the front side of that. Hamate, capitate, trapezoid, trapezium. Okay, so hopefully that's helpful, and we can move on. Let's look now at the flexor retinaculum. We've seen this picture before, but let's just take a look at this. It's basically just a fascia that keeps these tendons. Remember, we saw this in the ankle as well. Keeps these tendons coming on the forearm from bowstringing when they contract, because they're connecting from here all the way down to in this case, the flexor digitorum superficialis coming through here. It's attaching to the fingers, the middle phalanx of the fingers. And so when this pulls, you need to keep it tight here. So that's what this retinaculum does. Keeps it there. Again, you can see the ulnar nerve and artery should come in front of that retinaculum on the anterior side, on the ulnar side. And the superficial branch of the radial artery is going to come in front of that on the retinaculum on the radial side. The deep branch of the radial artery is going to go around back of that, but we'll kind of get there. Yeah, this area is very sensitive with wrist slashings. You can certainly damage, very easy to damage the ulnar nerve and artery here. They're very superficial. That's kind of tough. A little bit tougher to get to the median nerve, but though it can be done. It's usually it's a pretty substantial, a deep cut to get to the median nerve here. And this is really unfortunate when you have nerve damage, damage that involves the nerves. But you might run into that in your practice in the future. So be mindful of all the things involved with the wrist. If we look now at the extensor retinaculum, you can see that here, the extensor side. This tends to hold, this holds the tendons on the back of the dorsal aspect of the wrist, but these tendons on the extensor side are much more superficial. The flexor side, the palm side, they go through this carpal tunnel, which we'll see in a little bit here. But the extensor side, they're very superficial. You can feel them right on the back side of the wrist. They're just right underneath the skin. So that retinaculum really does do a good job of holding them nice and tight to the wrist. Okay, a couple things here on the metacarpal bones. Back to some anatomy. The metacarpals, named 1 through 5 from the thumb to the little finger here. Now, they're also named 1 through 5 from the great toe outside. But remember, on the hands, in anatomical position, you're going on the hand. You're going from lateral to medial. On the foot, you're going medial to lateral 1 through 5. So it's almost like the leg from the knee down is kind of put on backwards. I don't know if you've noticed that before, but in the naming of things. So it is a little bit backwards, medial to lateral, lateral to medial. Anyway, hopefully you get that. And then the phalanges, very similar to the foot. Distal to the metacarpals here, the digits 2 through 4 are going to have 3 phalanges, a proximal, middle, and distal, proximal, middle, distal, proximal, middle, distal. And then the thumb is going to have just a proximal and a distal phalanx on digit number 1. Okay, now let's talk a little bit about some circulation. We'll start on the palm side here. The palm side for circulation, you've got the radial artery coming down. You've got the ulnar artery coming down. The radial artery, there's a superficial branch that kind of splits right in front of that first metacarpal off the radial artery and makes an arch as it connects with the ulnar artery right here, kind of the superficial arch right here, okay? Off of that come these palmar metacarpal arteries. These are going to come off of that superficial arch, kind of the connection between the ulnar and the radial artery here. They're going to travel with between the palmar metacarpals and the bones here. Those are going to come together and form a common palmar artery. A common palmar digital artery coming up into the digits, and then that palmar digital artery splits into palmar digital arteries, and they're going to go on each side of the phalanges on each finger, on the palm side, coming up the sides, okay? Now, on the dorsal side, you'll also see this, but it's a little less robust here. The circulation on the dorsal side isn't quite as powerful, and you saw that with the thenar and the hypothenar eminence. We talked about the musculature being much more robust on the anterior, on the palm side, versus the extensor side. But here again, you're going to have kind of a smaller arc, a small superficial arch here from the radial. Whoops, didn't mean to do that. From the radial to the ulnar artery coming off this way, you're going to have those dorsal metacarpal arteries and then the dorsal digital arteries coming on the sides of the fingers. Now, here's a good little tip. If you do cut your finger, don't squeeze anterior posterior. Always squeeze on the lateral sides of your digits, proximal to the cut, because that's where the blood supply is, on the dorsal and the palmar side. They go up the sides of the digits, not on the anterior posterior side. So squeeze here and here. If you've cut your finger here, squeeze here and here, and just pinch that, and that will kind of give a little tourniquet and hopefully stop the bleeding until you can get more help if you need to. Okay, the carpal tunnel. Let's just touch on this. The carpal tunnel, when people say, oh, I've got carpal tunnel, you can say, oh, yeah, good. We all have 2 of them, 1 on each hand. That's kind of a snarky anatomy joke, but But the carpal tunnel is just this space here. It contains these 8 tendons, those tendons from the flexor. Oh boy, I just lost my mind here. The flexor digitorum superficialis and the flexor digitorum profundus are going to come down in through there, as well as some nerves and some vessels here. So let's take a look. You got the flexors tendons, you've got the ulnar and medial and median nerves, you've got the ulnar artery, and the superficial branch of the radial artery. They all go through that carpal tunnel. It's just this fascia tunnel here right underneath the flexor retinaculum. Okay, let's talk about the lumbrical muscles. Remember the lumbricals in the feet? It's the same thing in the hand. It's just kind of amazing, actually. These they come off of the flexor digitorum profundus muscle. They originate off of that flexor digitorum profundus. Here you can see the profundus continuing on to the distal phalanx of digits 2 through 4. But then these lumbricals come off of that of those tendons, and they'll actually travel back to the extensor hoods of those digits. So their function, again, just like in the feet, are going to be metacarpal phalangeal flexion. They're going to flex at the metacarpals and extend at the interphalangeal joints, at the phalanges. They're going to keep the fingers, the phalanges of digits 2 through 5 in extension. And this allows for you to move the hand as a single straight structure. So this is helpful if you're swimming, if you put your hand in the water and you get that catch and you're pulling that water. You want a little flexion at the metacarpals, but then you want those fingers, you want the digits to stay straight, so those phalanges need to stay straight, and that's where these lumbricals are going to attach to the extensor hoods and help keep the phalanges from extending. You also, if you're gathering something, if you're digging in the dirt, if you're pulling sand or grabbing onto a pile of something, this is what's going to help kind of flex at the metacarpals and then keep those phalanges straight. Okay. Let's now look a little on the back side of the posterior forearm muscles. You've been waiting for this, haven't you? So all these muscles are going to take their origin from a common tendon origin off the lateral epicondyle. Here you can see it's called the common extensor tendon. But all of these muscles are going to come basically from that lateral epicondyle. You saw that all of them except for the brachioradialis on the flexor side came from the medial epicondyle. Now the extensors are going to come from the lateral epicondyle of the humerus over here. Okay, let's first start talking about the extensor carpi radialis longus. So here was the brachioradialis. If we just follow that just one down from there, coming from that supracondylar ridge of the lateral epicondyle here, coming down, you can see it hooking down here, and it's going to come down and actually attach the proximal proximal portion of the second metacarpal, kind of that index finger. Is going to help lift the index finger up right here. The extensor carpi radialis longus. Now, if there's a longus, there's got to be a brevis, right? So the extensor carpi radialis brevis coming from that lateral epicondyle, it's going to insert down. You can see it coming underneath here. It's going to insert down onto the proximal third metacarpal bone. So the middle finger. These two are very commonly associated with tennis elbow, or lateral epicondylitis would be the term for that, where you've got the tendinitis problem up at the proximal elbow, but you can tell which one is being irritated, because if you have somebody hold their hand out straight with their fingers straight and you push down on the first finger, if that creates pain that they're familiar with, that's going to be the extensor carpi radialis longus. If you push down on the middle finger and say, don't let me move you, push down on the little finger slightly, and if that reproduces the pain, that's going to be the extensor carpi radialis brevis right through here. The extensor digitorum, let's just keep going towards the olecranon here, more laterally. You'll see the extensor digitorum muscle. So this is going to come again from the lateral epicondyle, and it's going to insert onto the proximal, I can't see it here, but it's going to go to the proximal, middle, and distal phalanges of digits 2 through 5. So kind of that making up that extensor hood all the way down the extension of those digits to help open the fingers up. And then you can see this one. Here's a funny one, the extensor digiti minimi muscle. This is going to come again, originating from the lateral epicondyle, but it's going to insert onto the proximal, middle, and distal phalanx of the 5th digit way down here. Now, most anatomists, I think, consider this to be part of the extensor digitorum muscle. Some feel that it's its own muscle. I don't really care, I guess. Maybe I should have an opinion. I think it probably is just part of the extensor digitorum, but it functions really. I suppose you could say the main function of the extensor digiti minimi, because it already has one tendon going to that little finger, but then there's another one. So we really, if you really want to feel cultured and hold your teacup with your little finger out, that would give you a lot of credibility at a tea party. But that will be using this extensor digiti minimi muscle there. Okay, so it's got its own thing there. The extensor carpi ulnaris, and keep going posteriorly here, or laterally, you can see the extensor carpi ulnaris, again, coming off of that lateral epicondyle and the posterior border of the ulna right in through here. That's going to insert at the base of the 5th metacarpal. Okay, so that's going to function to help extend and adduct, kind of ulnarly deviate the wrist. Right here, the extensor carpi ulnaris. And then you've got the flexor carpi ulnaris. Remember, we talked about that on the flexor side. So we've made our way all the way around the forearm here. Now, if we take that layer away, there's always a deeper layer, right? Let's take that layer away and look at a few other muscles here. One here is called the anconeus, or anconeus, however you want to say that. I call it the anconeus. The anconeus comes from, some people feel like this is just part of the tricep. Here you can see the tricep's been cut, but it stands out if you kind of flex your elbow and tense up your forearm. You'll see this muscle kind of pop out here on that extensor side. Originates from the lateral epicondyle and just inserts just to the posterior proximal ulna right here. So it kind of helps to just tighten up that elbow inflection. Here's a muscle called the supinator. We've seen this just once before, I think. The supinator, opposite of the pronator teres. This is going to come from the lateral epicondyle in the proximal ulna, and it's going to come over and insert on the lateral proximal radius. So when this pulls, it's going to pull the radius back into supination, making the ulna and the radius more parallel to each other again. So pulls the radius back over. So the pronator, coming from the medial epicondyle, pulling the radius into pronation. The supinator coming from the lateral epicondyle, pulling the radius into supination. So pronation, supination, pronator, teres, and supinator. Now we're going to get into 3 other muscles here. I think these are interesting muscles. De Quervain's syndrome is a tenosynovitis that happens near the thumb, and this is where these tendons can get involved here. There's 3 tendons that are important in this area. One is called the adductor pollicis longus, which is this one here. This is going to come from the posterior surface of the radius and the ulna. That's kind of a differentiator between these 3. We'll see where they attach being different. This is the adductor pollicis longus is going to come from both the radius and ulna, and it's going to insert on the proximal part. You can see here it's going to come down to the proximal part of the 1st metacarpal bone right there, okay, as an abductor. Abductor pollicis. If we go just below that, here you'll see the extensor pollicis brevis right here. Now this is going to come from the posterior radius, not the ulna, just the radius, and insert onto the proximal phalanx of the 1st digit. Okay, so it's going to extend the thumb, but coming to the proximal phalanx of the 1st digit. Now, if there was an extensor pollicis brevis, there's an extensor pollicis longus. Here's the extensor pollicis longus. This is coming from the posterior ulna. So remember, the abductor pollicis longus came from the radius and the ulna. The extensor pollicis brevis just came from the radius. The extensor pollicis longus is just coming from the ulna. And it's going to hook around here in that extensor retinaculum and then make a deeper cut going to the distal phalanx of the thumb down here. Now let's just kind of review what the definition of abduction and extension of the thumb. So abduction of the thumb is going to be to bring it away from midline. And extension is going to bring it posterior in a sagittal plane. It's going to go backwards. So extension and abduction of the thumb. This area here, you can kind of see these two tendons here and this one here, the extensor pollicis longus. If you kind of lift up your thumb, if you abduct the thumb and then extend it, you might see this kind of, there's a little space right here, right underneath where that radial artery would be. I learned this as the anatomical snuff box. Now that's a really old vernacular and probably not helpful anymore, but it would be, I'm told that people would put some tobacco in here, and it kind of creates a little bowl for that, and then they could kind of snuff it up into their nose. But this is, like I said, a common area where de Quervain syndrome, which is a tenosynovitis, where these tendons kind of get stuck in their sheath, pretty popular for them to get caught right in through the thumb area. Okay, and let's do one more. So we did abductor pollicis longus, extensor pollicis brevis, extensor pollicis longus, and then extensor indicis. That's an interesting muscle. Extensor indicis is going to come down from that distal posterior ulna again, and it's going to join with the extensor digitorum tendon to insert onto the proximal, middle, and distal phalanx of digit 2. This is the index finger, the pointer finger. So just like the flexor digiti minimi extensor digiti minimi rather, has its own, another little thing that comes off, so does the first finger. So the little finger and the first finger each kind of have another helper to help lift it at the phalanx. I guess this would be helpful if you're at a fancy restaurant and you want to flag down the server and you say, check please, you can kind of hold up your finger. Or if you're hailing a taxi, you can hold up your finger to do that. Or you could point at somebody and say, you, get over. That holding that index finger up straight, I guess is a important muscle, important thing to do. So we've got a couple different ways to do that muscularly. If we look at the hand again, just a quick view of this. The hand, you remember I talked about the extensor hood. All these extensor tendons create kind of this hood on the back of the dorsal side of all of the digits here. And so they kind of just come all the way through like that. Remember the lumbricals? Here's a lumbrical coming from the flexor side. That flexor digitorum profundus is going to branch off that lumbrical and come up and attach to the extensor hood. That's why it's going to be able to flex the metacarpal and extend the phalanges, right? So I just think that's pretty neat. That the feet and the hands, you've got this muscle that comes off another muscle that goes to the opposite side of the digit. Very, very useful, very functional. What a design. And then you've got, remember I talked about the flexor digitorum superficialis? That's going to come here and attach to the proximal phalanx, the proximal portion of the middle phalanx here, but it splits. It makes this V. It kind of cuts like this. That's tough. You can't really see it in this picture, but it kind of splits, goes laterally and medially. And then the tendon of the flexor digitorum profundus splits that V and goes to the proximal portion of the distal phalanx. So this is pretty cool, I think. Have you ever carried a bucket or something really heavy in your fingers where it's got that handle on your fingers? And you might carry it here, like at the tips of your fingers for a little while, but then that gets tired. So then if you flip the handle of the bucket and you go back to this knuckle, it's a little bit easier, and that might get tired, so then you might go back to the lumbricals. Here's superficialis, here's profundus. You've got several tendons in here that you can kind of flip back and forth between the proximal interphalangeal joint, the middle interphalangeal joint, the distal interphalangeal joint. You can see how that the musculature just allows for so much adaptation there. That's pretty cool. Well, I think it's cool. I guess then you have to, huh? Okay, let's talk just a little bit about joints, then I'll finish up here. So the joints, what we're not going to do is dissect the cadavers to see these joints. I would love to preserve the beautiful dissections that you've done to this point, so we're not going to mess the joints, the dissection up just to see some of the joint structures here. I think we can do good enough to learn this with the models. We've got good models of this in lab. And these pictures in Netter and just in other texts that we'll see. That should be sufficient. But let's look at the shoulder joint here very quickly. Let's review the glenoid cavity, which is part of the glenoid fossa of the scapula. right? The socket of the shoulder joint. And then you've got the humeral head here, the proximal portion of the humerus that fits into the glenoid cavity. That allows for that ball and socket joint, that synovial joint, to get a lot of that movement. Here you've got the labrum, this fibrocartilage rim that goes around, kind of surrounds the glenoid fossa. Because remember, only about 17 or so % of that ball is in contact with the socket. It's almost exactly like putting a golf ball on a tee. The surface area of the ball that's in contact with the tee, that's what we're talking about here. It's really shallow. The most mobile, most unstable joint in the human body is this glenohumeral joint. And then these ligaments on the front, we'll just learn them collectively as the glenohumeral ligaments. These come across the anterior aspect. The posterior aspect of the shoulder is actually much more stable than the anterior aspect because the scapula is there. The glenoid cavity actually fits much of the back side. The posterior aspect of the shoulder joint is the glenoid cavity. The anterior portion, though, is just wide open here. It's much more easy to dislocate anteriorly than posteriorly. Okay, let's look at the elbow. A couple of ligaments quickly here. On the medial side, the ulnar side, you can see there's an ulnar collateral ligament. It's got 3 bands to it. There's an anterior band, a posterior band, and an oblique band. Remember we talked about the palmaris longus tendon. That's sometimes used as a graft if you need a Tommy John surgery or a UCL surgery to repair a torn ulnar collateral ligament on the medial side. The radial side has its own. There's a radial collateral ligament coming from the lateral epicondyle. Here's the medial epicondyle to the ulna. Here's from the lateral epicondyle to the radius. So you can see, and the ulna here coming down, but it's got an anterior and a posterior band there, providing some support more laterally. So medial, lateral, radial, ulnar. And then here's a cool ligament, the annular ligament. Now, when you hear annular, what does that remind you of? The calendar, a year. The Greeks originally had a calendar that was in a circle. It went around, and so you think of going around the moon, or around the sun. Maybe in our day, we can talk about another lap around the sun, annular. But it's going to come from the ulna, wrap around the head of the radius, and attach again to the ulna. Right? It's basically holding that head of the radius into the capitulum of the distal humerus, keeping it snugged up into that elbow joint. Now, be careful with this one because this can dislocate. If you ever see people, maybe annoyed parents of young children, take their kids and kind of get over here. They take their arm and they pull really hard on their hands and their arm, and they pull them hard. You can dislocate this. You can pull the radius out of this annular ligament, dislocating it there. Or if you're babysitting possibly, or if you've got small kids at home and you give airplane rides. I remember when I was a kid, that was a popular thing my parents used to do, is give airplane. You grab onto the kids' hands and swing them around so their feet are off the ground, but you're putting all of that weight plus all that centrifugal force through that annular ligament, and if that you could pull the radius right out of that ligament. Now, I'm embarrassed to say that I've done this to both of my daughters. I didn't do airplane rides. I didn't yank their arm in a fit of fury at a grocery store, but very benign, very easy things. I remember one of them was just jumping on the bed. They were very little. I was standing on the ground. I had their arms. They were jumping up and down. And somebody came in the room, or I walked down the hallway, and I kind of turned my head to look away, but they're still jumping. I'm still hanging onto their hands. And then they jumped off the bed, but I wasn't looking. And so I felt their hands go down out of my hands. So I quick grabbed, reflexively pulling their arms up, and then dislocated that radius from the ulnar ligament. And you should see how quickly a young daughter's face can go from just joy to total, I don't know, pain, panic, really, really mad. What did you do? And so I knew enough about this. Thank goodness. It's very quick. You can just kind of shove this back in real quick. You've got a few seconds before the nervous system takes over and really tries to protect it by not allowing any more movement, and you can kind of shove that back in. But anyway, that's a long story. But be careful of dislocating the proximal radius. We'll finish up real quickly here, just talking about the joints of the hand. We're not going to get too deep with this. There's a lot, we talked about a lot of synovial joints having a limited amount of motion in each at the wrist, but together, collectively, having just a tremendous amount of maneuverability and dexterity. The hands are just an amazing amount of ability to move very precisely. And then you see in the phalanges here, basically just synovial joints with capsules with synovial fluid contained inside there. That's all I really want you to pay attention to for that. Well, that does it. That ends our lecture series on the back and extremities. I hope this was helpful. I hope you learned something, and I will look forward to seeing you in lab. Thanks for your time.